Good morning, everyone. We're going to get started in a couple of seconds, so if you would please take your seats. Good morning, everybody. I'm Seema Kumar. I'm Vice President for Innovation, Global Health, and Science Policy Communications at Johnson & Johnson, and I'm delighted to introduce this next session. I want to begin by saying that at Johnson & Johnson, and I think many of us here, believe that big, audacious goals, moonshots, are not impossible. They're in fact achievable, and making them a reality is what we aspire to do every day. As many of you also know, when HIV emerged in the early 1980s, nobody could have predicted that we would be where we are today, being able to solve it with one pill once a day. Back then, of course, being diagnosed with HIV meant that you had 1 or 2 years to live. And today, due to the work of a lot of scientists across the globe, and a collaboration between patients, physicians, scientists, industry, academia, governments, we have turned HIV into a manageable condition. But our work is not done yet, because the progress we've made in the past three decades is not enough to solve the big problem that HIV still presents across the globe. And ultimately, we can't treat ourselves out of HIV. So really, what we need to do is to aim for the next moonshot, and that would be the HIV vaccine. And I'm pleased to say that we at Johnson & Johnson, along with NIAID, and many of you who are here on the panel and are involved in working towards a vaccine candidate or several vaccine candidates so that one day we can live in a world without AIDS. So with that, let me turn it over to Olga Hansen and from the Atlantic to moderate this session. Thank you.
Great. Well, thank you all so much for being here. We're here to talk about a problem that's been with us for a very long time, but we are now actually talking about what will it take to actually end HIV/AIDS. And I'm here with 3 people who have worked on this issue extensively. First to my right is Anthony Fauci, the director of the National Institute of Allergy and Infectious Disease. Then I have Jamila Headley, the director of the Health Global Access Project. And finally, Andrew Whitty, the chancellor of the University of Nottingham and the former CEO of GlaxoSmithKline. So first, I wanted to just ask each of you, kind of from your perspective, what is the biggest misconception about HIV or AIDS today? And anyone can start.
Go ahead.
I think one big misconception is that, at least in the United States, is that it's no longer a big problem. Last year, we had 1.1 million people around the world die of HIV and AIDS, or of AIDS-related complications. And so this is not a problem that is over at all. We spent quite a bit of time yesterday talking about emerging pandemics. This is one that is still very much with us and very much needing our innovation and our energy. But pairing with that is the fact that while we know it's not over, we do think it's possible to really turn the bend on this. We have had a lot of great advances over the last few years, including seeing the power of treatment in acting as prevention and in helping us to reduce incidence globally. So there's both a concern, I think, a misconception that it's over, and a misconception about the tools that we have to fight it.
So to underscore that, we have to testify many, many times before the Congress in the position that we're in the executive branch. And years ago, whenever we would get up, there would be a rather substantial proportion of questions asked about HIV/AIDS. For the last couple of years, in the testimonies that I've made, there has been anywhere from 0 to 1 question about it. And I think it's related to the issue that Jamila has brought up, is that there is this perception, which Olga is a misperception, that because we have life-saving therapies and we have treatment as prevention and we have pre-exposure prophylaxis, that these things are going to happen spontaneously. And as I've said very often, there is this misperception that if we just keep things going as they're going, things are going to attrit and go down. And they're not, because as I've said so many times, we have a major implementation gap in implementing the scientific advances that we've made. Nobody is going to argue with the breathtaking scientific advances. But what we have is a problem of implementing them globally and having the will to do it. And the perception is that, okay, we've taken care of HIV, let's just move on to something else. And in fact, getting back to the arena of congressional hearings, I was asked last year by a congressman at a budget hearing wanting to say, you know, didn't we solve this problem? Why do you have to have so much money in AIDS? Why don't we just move it out into something else? Clearly reflecting this misperception that you're talking about.
Yeah.
I mean, I'd certainly share absolutely the perspectives you've just heard. I think there is too much complacency. I think all evidence of previous infectious agents is that you become complacent at your peril. They have a powerful potential to spring back. This is by far and away the cleverest infectious agent we've ever tried to deal with, which is why it's so difficult to find a vaccine. I think there's a drift in, really as Tony's just made the point, I think around the world, other issues have crowded in areas like government and focus areas where you want resourcing. And honestly, as somebody who's just stepped down from running the world's biggest vaccine company, while I'm hopeful around vaccine, we are a long way away from being in the bank on a vaccine. And I think there is a little bit too much belief that we're much nearer to that than perhaps we are. Maybe I'm wrong, but this is not a trivial thing to vaccinate against.
Can you talk a little bit about why it's so difficult to create a vaccine for this?
I mean, really, the same reason that the virus is so powerful and so effective, because if you had to design, I mean, if you had the job of designing a clever beast that could somehow hijack the human and hide itself and protect itself from all of the normal tools we would use to kill it, this is it. I mean, it is really extraordinary the way it lives inside our own immune system, and to go after it as a consequence is super challenging. And huge, I mean, for decades, I mean, really from the beginning, the vaccine has been a dream, huge amounts of efforts, lots of progress. But we're still a ways away. And I think for people around the world who are thinking, you know, in the next 10 years we have a vaccine and this whole thing is going to be history, I think that's a very optimistic view.
Yeah, no, there's an even more cogent reason. I totally agree with what Andrew said. But, you know, from the time that I was in medical school, all of my mentors would say the best way to make a vaccine is to mimic natural infection. Because if you look at all of the killers and the infections that give big morbidity, smallpox, measles, polio, even though there's morbidity and mortality, at the end of the day, the body's immune system clears the virus and induces an immune response that protects you against reinfection with the same microbe. That's the way we have been making vaccines forever. Now we have a virus in which, for reasons we still don't completely understand, the body does not like to make an effective immune response against this virus. It makes an immune response, but it's not effective enough to completely suppress replication and to completely eradicate the virus for some of the reasons that Andrew mentioned. So we have a very ominous task now. We have to do better than natural infection. The best way to protect yourself against an infection is to get infected and get over it, and then you won't get infected again. You can't do that with HIV, but a vaccine is a challenge to how do we present to the immune system a component of the virus that would elicit a response that natural infection is incapable of doing. That is a very difficult task.
Yeah.
So I feel like I need to balance like this really morose view right here. Yes, the vaccine is really far off, but you know, we have pre-exposure prophylaxis that can prevent people.
No, we're talking about a vaccine.
I know, a vaccine, but I'm just saying in terms of fighting the epidemic, I think often the orientation is that we need a vaccine to end the epidemic, right? When we talk about ending the AIDS epidemic, we're talking about ending the pandemic proportions that we see of AIDS and having a world where no one is progressing from HIV to AIDS, right? And so we have lots of technology there.
No, I totally agree. And that's why I was a little bit put aback by your introduction. Yeah. We have a lot we can do without a vaccine. Yeah. I mean, we have the scientific capabilities. If we implement them, we could turn around the trajectory.
So much
what?
in vaccine.
Well, we're investing so much because if you want a durable end to an epidemic, but if we have 2 million new infections a year, it's been that way for a very long time, despite PrEP, despite treatment as prevention. That's the reason why we need it. And the reason why incidence has not gone down is because we have not implemented treatment as prevention, and we've not implemented PrEP. Right. If we did it, I mean, you know the 90-90-90 paradigm that they say, that if you get 90% of the infected people diagnosed and you put 90% of them on therapy and you viral suppress 90% of them, you'll have 73% of the world who's infected virally suppressed. If you do a mathematical model on that, the epidemic starts going like this. We're not even close to that. We're about 38%.
Just to put that in perspective, you know, almost no one in the global south has access to PrEP, right?
Wait, so why is that? Why?
Right, like lack of resources, and we should talk about that because we're in a precarious position right now with the U.S. government potentially making major cuts to resources for this fight. You know, in South Africa, there's still only 47% of people living with HIV on drugs, on treatment, right? In a country with incredibly high prevalence, where we could see real gains if there are higher treatment coverage. You know, and then we are seeing gains in countries like Zimbabwe, where we have 74% of people now on treatment. We're seeing incidence drop dramatically. So again, there's a lot of hope, and there's a lot that can be done, but we're not implementing. Right?
I wanted to ask you something, Jamila, from your notes, which is that you mentioned that stigma and racism actually plays a role in why people aren't able to get on this pre-exposure prophylaxis. Can you talk a little bit about those issues?
So Dr. Fauci talked about how sophisticated the virus is, right? And one of the things that I think is also striking with HIV is that there's this sophistication in the world, in the social world, about how the virus is transmitted and how it interacts. The way that power or lack of power, the way that gender, the way that race, the way that sexual orientation has played a role in whether people have been vulnerable to this infection is quite marked. And it's one of the reasons why I find HIV so fascinating, because it interacts with all of these social issues and ills that many of us care so deeply about. You know, in several countries in which we work in, you know, in Zimbabwe to the same country where I showed, you know, they're making big gains on incidence. If you look at what's happening among men who have sex with men in Zimbabwe, prevalence is still 3 times that of the general population. Yeah. Coverage is still incredibly low. So even where we are reaching a lot of people and we're increasing coverage, the 10% from that 90% of people on treatment, that UNAIDS goal, who's in that 10% are people who don't matter as much to society, who are left behind, people who are marginalized or criminalized. And we won't end the pandemic if we don't get at that.
What about, I mean, how big of a role is especially for women who are at risk of infection, a fear of kind of upsetting a partner? I don't know, I was reading this story about how, you know, the vaginal ring that contains, I guess, PrEP, a lot of women actually don't want to use it because they're worried that it'll prompt some questions from their partner about why they're using it.
Yeah, we need better technologies for women. We've had really dismal kind of progress with microbicides, with other things that we hoped would work. We know, for example, in sub-Saharan Africa, where the rates of HIV prevalence among young women and kind of adolescent girls is incredibly high, that, you know, many of them don't choose their first sexual encounter, you know, don't have a lot of control over when and how they have sex. So we need technologies for women that work and that don't require them to negotiate with a man. One of the things that PEPFAR is doing through their DREAMS initiative is really rolling out PrEP for young women. And I think that that's interesting because they can take a pill just as they would take a birth control pill and help to prevent transmission of HIV. But we don't have all the technologies we need, I think, yet to really help protect women.
Yeah. And Dr. Fauci, I wanted to turn to you because you've really been working on this since day one. And we actually have a part of the AIDS quilt here at Aspen that you guys can go see if you're interested, which is from the early 90s, actually. And I just was wondering if you could tell us sort of how has the life expectancy of someone with HIV changed since you first started working on this? You know, let's say they do get access to PrEP, right. They are in treatment. How does that change kind of what they're looking at as far as life expectancy? And then I was also wondering if you could tell us about the San Francisco model of kind of overcoming some of these barriers and getting people in treatment.
So I started taking care of HIV-infected individuals before we knew it was HIV and before we called it AIDS. It was in the summer and fall of 1981 when the first cases were reported from Los Angeles, San Francisco, in the United States, and I kept bringing patients in. And when they came in, since we didn't have a diagnostic, they would only come in when they were sick with advanced disease. So the life expectancy, the median survival of my patients prior to therapy was anywhere from 10 to 14 months, which means 50% of them would be dead. And if you followed them longer enough, as I did, almost all of them died. There were very few exceptions that did not. Now that we have combinations of drugs, which we used to have to give 25, 28 pills, we can now give it in one pill, one single pill with 3 antiretrovirals in it, that if someone comes in, a 25-year-old person, man or woman, comes into the clinic where I see my patients at the NIH, and I put them on therapy and they took their medications religiously, I could look them in the eye and tell them quite honestly that if you do actuarial curves, that they could live an additional 50 plus years, which means if you're a 25-year-old person, you have almost a normal life expectancy. Now, there are a lot of other complications that go along with comorbidities, but that is an absolutely huge issue that we have that's very, very different from what it was right now. And getting back to the first comment that I made, Olga, about the implementation gap, one of the things that we see, it has a lot to do with the healthcare delivery system, even in the United States. I live in Washington, D.C., and in our clinic, we have people come in 2017 who were diagnosed 5 or 6 years ago. They got shot or in an automobile accident. Somebody did an HIV test, and they either never came back for the result, they got a prescription and didn't fill it, they filled the prescription, but they didn't take the medication. So now they're coming in with a CD4 count of 12 in 2017. That's completely unacceptable. The San Francisco model that you're alluding to is that the steps, and we call it that steps that go from the treatment cascade, from the time that you get infected to the time your viral load is suppressed. There are multiple vulnerable steps there, and the vulnerable steps are the things I'm telling you about. Do you see a doctor? Do you get diagnosed? Do you fulfill your prescription? In San Francisco, they have something called the RAPID model. You should just Google it. It's really a very interesting thing. They are incredibly aggressive in getting the people who don't have access to health care. They go to gay bars, they go to homeless shelters, they go to prisons, and what they do, they'll go over to a person, and if the person's at risk or not, they'll draw their blood, and they have those capabilities of determining if you're positive, like in 15 to 20 minutes. If you're positive, they're not gonna go with the confirmatory test and let's do this. They give them a bag of antiretrovirals that lasts for a month and a prescription to fill. They then say, do you have a cell phone? If they have a cell phone, they take their number and call them in a month to see if they've done it. If they don't have a cell phone, they give them a cell phone. Now, that is really aggressive, but based on what Jamila said, what's happening in San Francisco, where you have so many of the disenfranchised people who a healthcare system would never get, the incidence in San Francisco is doing this, much more rapidly going down than any other place.
So I have to ask, about the U.S. government policies, which, just recently, we've had the reinstatement of the Mexico City policy, the global gag rule, the budget proposal coming from the president, which proposed cuts to AIDS prevention and research, and then also 6 members of the Presidential Advisory Council on HIV and AIDS resigned in June. What are your perspectives, and I realize they might all be different perspectives, on whether, how this will impact the fight against AIDS around the world or in the U.S.?
Can I add one more thing to that?
Oh,
and then I maybe will let someone answer.
This sounds like an Andrew question.
We also just had a leak. We just had a leak yesterday that there will be an executive order on pricing of medicines, which has a number of proposals that we think will do just the opposite of reducing the prices of medicines so that they're accessible for many people around the world. So I just want to add that to the list of things, and I'll let one of these start. And jump in later.
I think well, all of these signals, individually may or may not have a particularly big impact, but they do crowd together and they start to send a message more generally. And that message I think can be interpreted in a number of ways. For some, it gives people permission to deprioritize this as an area of focus. And as we all said at the beginning of these conversations, there is a gigantic mistake to be made by thinking that winning a battle means you won the war. And because we won a battle in terms of developing treatments and getting some deployment in, large scale, very large scale actually, compared to historic norms, but nowhere near 100%, clearly means the war still needs to be dealt with. I think there is it would be very difficult to underestimate how pivotal the US has been in the last 30 years of driving global behavior to try and do something effective here. And I think if the US is going to retreat from that position, both from a policy point of view and a funding point of view, it would be very naive to believe that there's somebody sat around who's just going to fill that void. I think that's very unlikely. And I think that risk at the moment where perhaps complacency is already a present danger is a pretty frightening situation. And just as you see, in London, you look at the chemsex epidemic that suddenly kind of burst in the last 3 or 4 years, what that's doing to drive new infection in a highly educated environment with a good healthcare situation, starting to turn trends into reverse. You can see very similar sorts of phenomena happening on much bigger populations by simply taking away the pressure which has been there for the last 10 or 15 years. If you think about the opportunity that we might be missing then, as Tony said, more and more evidence of how we can nail this from a behavioral point of view, more and more evidence of how we can work together in a systems way. The San Francisco model is a tremendous example. We have got new technologies coming. We're not that far away potentially from a once a month or once every 8 weeks treatment, so people don't even have to take a pill every day. Those sorts of opportunities are potentially in sight in the next few years. I think it would be a great shame if just at that moment, what has been an extremely positive pressure just weakens or disappears and the whole world goes backwards.
With infectious diseases, and we have examples historically with malaria and with tuberculosis, where you're looking at control, elimination, or eradication, and you're doing a really good job, and you almost get there, and you take your foot off the accelerator, and you concentrate on something else. And infectious diseases are different than other diseases. They're self-propagating if you keep them out of control. If you control them, they tend to decelerate as long as you keep doing it. Once you pull back, there's no doubt that we're going to have a problem that we're going to have to pay the piper 5-10 years from now, because right now we need to get those incidents down. We're doing very well on treatment. And as I keep saying, we have the tools. With all due respect, we do need a vaccine to durably end it, but we have the tools to essentially turn it around. And it's a big implementation gap if we don't implement them. And that is something that's very frustrating, because you can almost see the end coming, and if you pull the pressure off, it's going to be bad.
One of the things I think we need to, as a community, we need to re-challenge ourselves on is a couple of things. Going back to the late 90s, 2000s, I think the US government was really astute in the way it identified global health as, in fact, a global security issue. And I think that massively expanded people's mind in terms of why it was worthwhile to engage on a global basis in this kind of agenda. I think that issue has not gone away. You look at what's driving migration across the world, you look at what's driving a lot of the issues across the world. Health and inequitable access to health is one of the component drivers of that. And I think we've got to get back to that kind of understanding of how this plays a much bigger role, first thing. The second, there are always economic pressures. We all know that, and we know that there isn't an endless amount of resources. So we have to be more efficient in what we're doing. And we have to look at what we've achieved over the last 15 or 16 years in not just HIV, but what we've achieved in Gavi through vaccine delivery, what we've achieved in neglected tropical diseases, what we're achieving in a number of strands. But we've done all of those things in somewhat silos. But we've learned a lot. And what we've learned we ought to be starting to weld together in a much more comprehensive approach. At the end of the day, and you're going to hear this many times over these few days, of course it's all about the last mile. But you know what? The NTD last mile and the HIV last mile and the vaccine last mile, it's the same last mile. And we need to be much more thoughtful about the lessons that we've learned in all of those environments, and then how can we start to bring them together so we get a much more comprehensive impact? Can we work together much better on community health care workers? What can we be doing to make it easier for policymakers to continue to be there to support and to drive funding by demonstrating we can make impact, we can significantly expand coverage, and we can do it efficiently, and perhaps more efficiently than we have done for the last 20 years.
Go ahead.
Yeah, I want to really contextualize the potential impact of what's happening in the US right now. My colleagues have said it's big. I want to argue that it could have a devastating impact on the fight right now. Three things I want to highlight. Global gag rule, or the Mexico City policy being reinstated. I was just in Mozambique with colleagues where we're working on implementing an innovative program really drawing from the San Francisco model for men who have sex with men in that country. One of the organizations that provide really great linkage to treatment and prevention for men who have sex with men will be affected by the Mexico City policy. That organization will lose 2/3 of its budget.
Can you summarize
for doing
them
work?
What the Mexico City?
So what the Mexico City policy says, well, what they say on the surface is it's to prevent the use of U.S. funds for abortion, for providing abortion or promoting abortion. Now, I have to be really clear, there are no U.S. funds used to provide abortions. There's legislation that prevents that. There's no money that is used for that. What the Mexico City policy does is that any organization receiving U.S. funding for anything for global health cannot use other funds to provide or promote, which could involve advocacy, handing out a pamphlet, counsel, abortion access. So this organization, which will not sign the global gag rule because they do provide essential abortion services in Mozambique where abortion is legal, will lose 2/3 of its budget and be crippled in its ability to provide services. So that's one very minor kind of one organization, but real impact of the global gag rule. 2, funding. The Trump budget, which let's also be clear, it's not over yet. This is up to Congress to set the budget, and we hope that they will do the right thing. But $2.5 billion cut to global health overall, $1.08 billion to global HIV programs. I want to detail some of these cuts because it's important. A 17% cut to the global fund, a 10% cut to the State Department's HIV funding, global HIV funding, elimination of all USAID funding for global HIV, a 50% cut to the CDC global HIV funding, elimination of all funding for the International AIDS Vaccine Initiative. These are profound. Estimates show that we think at least 1 million people that 1 million people will be affected as a result of these cuts. So this is not minor, what we're being proposed. Second, the third thing is the new executive order on access to medicines or on pricing of medicines. I wrote down a quote from it because I think it's really important. Instead of focusing on the monopoly of medicines that contributes to high prices, or on R&D and marketing and all of that, and challenging the real drivers that we see of exorbitant prices of drugs. This executive order identifies the main problem as foreign countries who are abusing American innovation by paying cheaper prices for drugs and accessing generic drugs. And so the entire executive order is focused on going after countries that are using flexibilities to be able to break patents to provide drugs for their people. It says, extension of patent life for medicines overseas will ensure that Americans do not unfairly subsidize R&D for people around the globe. This turning inward of American policy to focus on America first is incredibly dangerous from a national security point of view, which is not an argument that I like to use, but also hugely unethical. In a world where the US comprises most of the world's wealth, right? When we started this fight, it wasn't just because, as activists, it wasn't just, it wasn't charity why we were saying that countries in the global north should get engaged in this. It was also because we felt there needed to be a fundamental redistribution of resources in a world that is just profoundly unjust and economically unjust. So I'm really concerned about what's happening in the US right now. We are fighting hard on the Hill and elsewhere to make sure that this doesn't happen, and we need everybody else in this room and elsewhere to be doing it too.
So just to play the very mildest of devil's advocates, I think when some people hear arguments like that, they say, well, but Congress is never going to pass the blueprint budget. They're going to make changes. There might be a continuing resolution. So many things might happen. What would you say to that argument?
Congress is having to make difficult choices, and Congress has pressures from elsewhere as well. We're talking about proposals to increase the military budget quite substantially. Where will that come from? So we know that they will make difficult choices, and we know that our interests here in global health won't be protected without a fight. We hope that Congress will do the right thing. We cannot be sure that it will all be protected, because within the foreign assistance budget, they are making really huge decisions and trade-offs. Now, my sense is that we need to reject the idea that there's limited resources for global health. When we look at what the US is spending on military spending, to what effect, right, which we should question, I think there needs to be more questioning of the overall distribution of resources in the country. But with the fights around domestic health care, we have a really difficult kind of arena in which we are trying to insert that Americans should care about people elsewhere right now.
So I wanted to turn back to America, because we do have, we have a real injecting drug use problem right now. And I was wondering whether that is affecting HIV rates or treatment, and sort of what's being done around HIV and the opioid epidemic specifically.
Well, the percentage of new infections by injection drug use in the United States has dramatically decreased. There was that Indiana outbreak, which tells us that risk looms large. So if we're having, which we have heard very elegantly from Vivek Murtha and others, about the opioid crisis that would lead to injection drug use, then there's always that danger that we will see a resurgence, because right now in the United States, if you look at the pie of infection people, the vast majority, well over 55%, are in African American men who have sex with men. The injection drug use slice of the pie did this until we hit the Indiana outbreak, which was really a major epidemic in a very small region of the country. The fact that it could happen in Indiana, given the opioid crisis we're having now, I'm concerned that we may start seeing blips like that in the future, so we have to keep our eye on that.
It's particularly concerning when there's not good policy around harm reduction and other methods that we know help protect people who inject drugs. And when the drug war and the kind of criminalization of people who inject drugs in this country continues, we know those things help drive an epidemic when vulnerabilities like this emerge.
Yeah. Well, so I wanted to ask, because I was recently actually in a doctor's appointment with a man who, as he learned that he had HIV, and it was just really affecting for me to see how that news impacted him and his struggle to kind of deal with that diagnosis. I was wondering kind of how doctors these days communicate that to their patients, that you have HIV, but it's not a death sentence, or what do you tell people to encourage them to take medication, to encourage them to stay positive despite the diagnosis?
Well, I see a few patients whose diagnosis is brand new. I usually get referred patients who have already been diagnosed. But in our clinic, where we will make a diagnosis of a patient, and certainly back early on, how you address a patient today versus the 1980s is different. But if someone comes into an office now, you should never underestimate the emotional trauma that a person, even in an arena in which you have effective therapies. So you have to be realistic about what it is, but there's a lot of encouragement that you can give to patients. So you've got to be sensitive to the trauma that they have with this, which could be a life-altering situation for them. But then right now I find that patients really want to hear the details of what we know now about the virus, what we know about the projection of the drugs, what the toxicities of the drugs are. So it's an entirely different patient-physician interaction in 2017 than it was in 1985. I mean, just like day and night difference.
How is it different?
Well, it's different because, I mean, I have to say, I've written about this, that from 1981 to 1987 were the darkest years of my professional career, because you had to counsel people in what what the reality is, that things were really bad. You gave them encouragement about treating opportunistic infections. In 1987, when the first drug AZT was approved by the FDA, we had a blip of hope in that individuals who were essentially going downhill essentially did well, but for a limited period of time, because of a single drug with an RNA virus, you could predict you're going to have resistance. We tooted along to 1 or 2 drugs, and then when we got to 1996 and beyond, when we had the triple combination, first with protease inhibitors, but now with integrase inhibitors and others, it's much, much different, because you could project, like I said in the first question that you asked me, Olga, that you could tell a person to motivate them to take their drugs and to take good care of themselves, that they could actually live an essentially normal life. Now, the thing that's interesting, and I just want to throw this out, when people get complacent about infection by HIV because we have life-saving drugs, we've got to disabuse them like that. I don't know any of my now thousands of patients that I've seen who would rather be infected than uninfected. Yeah. So this idea that it's okay, we have great drugs, is just really a fallacy. It just is. So the most important thing, as we were talking about with PrEP and doing everything we can to prevent infection, is absolutely critical. But when a person is infected, there are so many things that they can do to live a normal life. So it's a different dialogue that you have with the patient now than when you were facing almost a certain, if not a death sentence, certainly a lot of suffering and morbidity.
Can I add something to that? In many countries now, in addition to doctors and nurses and community health workers who deliver the news of an HIV status, we're finding that things like community adherence clubs or groups where other people living with HIV are journeying along with them and create a community that helps to share with them the impact of the medicines on their lives, that help to check in with people to make sure that they're taking their medicines, and really to help that psychological journey of getting a diagnosis, getting on treatment, and staying on and staying adherent to treatment, that we found that communities and people living with HIV play a really critical role in the response as well.
Well, I was reading recently that, in Venezuela, there's actually been a rise in HIV and AIDS cases because of the awful, economic breakdown and the breakdown of the health system there. And I was wondering, looking around the world, what are some other places that you guys have seen where you have seen a resurgence in infections where you wouldn't necessarily expect them, and it's because of something like, that outside of just people having more unprotected sex. So political instability, refugee flows, what have you. How do all those things affect infections?
I think it's kind of obvious that the minute you lose structure to healthcare prevention, education, provision of meds or provision of testing capability, then you inevitably see a return to trend. And you would have exactly the same conversation if you looked at malaria prevention, you looked at tuberculosis prevention. It's an infectious, it's not going to go away. Right? This virus is here forever. And it's pressurizing. You have to, I think what we all have to just remember is all of these viruses, all of these infectious agents are pressuring the human state all the time. And if you relax your diligence, then it is going to break through. And if diligence means you suddenly think high-risk behavior has no consequence, and actually everything's going to be okay, then that's going to lead to a breakthrough. If it's a breakdown in drug supply, for example, or a lack of education, or a collapse in economic activity, so for example, women become even more exposed to risk than they were in the previous time period, you're going to see those spikes, and they're going to keep coming. And which is why having a relentless, comprehensive, multi-layered approach is so important. Now we know that works. There's not that much to be invented to get to the end of AIDS. The question is comprehensive delivery and sustained delivery, which is why robust, consistent policy frameworks, robust, consistent funding frameworks, and best practice sharing are key attributes to getting this done. The risk at the moment is, for the various reasons which have come up in this conversation, there's quite a lot of distraction. And actually, the risk is that we'll end up going back 10 years rather than going forward 10 years.
In recent years, there's been a move towards kind of rationing resources, global resources for HIV. That we've had declines since 2014-15 in terms of overall funding for HIV. And one of the ways that people have rationed, and the Global Fund to fight AIDS, TB, and malaria is included in this, is to say, we will give less money or no money to middle-income countries. Let's focus on the poorest of the poor countries. The fact is that many middle-income countries are not able to provide healthcare for all of their people and are in very fragile states. Kenya just became a middle-income country last year, for example. 90% of its HIV program is funded by donors, right? And so middle-income countries take a while to move to amass enough tax, a strong enough tax system, a strong enough health system to be able to carry this burden on their own. An example of this was that the Global Fund in 2013 stopped funding to Romania, completely cut funding. Romania has what we call a concentrated epidemic. It is largely among people who inject drugs and men who have sex with men. The government is quite antagonistic towards people who inject drugs. Drug users are criminalized or imprisoned, and had invested very little in programs that we know that work, like methadone programs, harm reduction programs. When the Global Fund pulled out, the government was not there to pick it up. These were not services that they cared about. We saw incidence and prevalence in Romania go up in the last 4 years. So we know that when we take our feet off the gas, things go up. We know that many middle-income countries cannot carry this burden themselves, either because of stigma, discrimination, criminalization from governments, or because of economic instability. My own country, Barbados, an upper middle-income country, is right now in severe financial crisis. So while we were one of the first countries, we were the first after Brazil to provide universal treatment access for people living with HIV, we're now in a situation where we're hard-pressed to find gloves or alcohol in the public hospital. So there are many countries that are really on the precipice, and as we take our feet off the gas pedal and as we decrease funding for HIV, we're in a much more precarious position, I think, than many people realize.
Yeah. Anything to add? No? I'd like to take some questions from the audience. If you guys up here, I think you were first. There's going to be a mic runner that comes to you in the blue shirt. Oh, if you could stand up too.
Oh, sure. Great. Hi, good morning. My name is Andrew Paolini. I work for Pharma, the trade association. Thank you all so much for being here. This is just a really emotional but inspiring panel. I had two questions. One was on PrEP. So who should be on it? And then secondly, there seems to be a little bit of a misunderstanding regarding prescribing and adherence regarding PrEP medication themselves. So how can we do a better job of educating people about proper adherence and prescribing? Thanks.
That's a great question. The CDC has estimated that there are at least 1 to 2 million people in the United States, and there's different issues with other countries, but just for clarity, take the United States, who are at high enough risk that they could benefit greatly from PrEP. But there are some statistics that are a little bit disturbing. 1/3 of primary care physicians to whom these individuals might go to have never even heard of PrEP. So that's problem number one. 10% of the people who could benefit from it are on it. And that's really unacceptable when you have something that can actually up to 95+%. In fact, there have been studies that shown, and there's been a lot of confusion about adherence and efficacy, and I could summarize that in less than a minute. The first study that we did at the NIH was a study in which you looked at all comers. It was what we call intent to treat. So you assume everyone is going to be taking the medication. The total efficacy of it was 47%, which isn't particularly good. But if you went back and said, now wait a minute, let me look at these data in a post hoc analysis, I will only count the data for people who tell me they actually took the medication. It went from 47% to 72%. And then if you say, I love you, but I just don't believe you, I'm only going to count the data of people whose blood levels showed that they took Truvada. The efficacy went up to 95%. So this confusion out there that whether it works or not, it absolutely works. There have been cohort studies that were done with, in San Francisco where you had a nurse-driven study that gave people PrEP, and then you looked at people who weren't using PrEP. There were no infections in the PrEP group and 82 infections in the individuals who didn't. So people say, well, giving somebody PrEP would be an excuse for them not to have safe sex in other ways. You have to be realistic about what life is and life behavior is, because those people likely are not going to use condoms anyway. So the issue is, if you have a prevention modality, that it should be advertised in the sense of make people aware of it. You shouldn't say this is a substitute for condom. You should say it adds to your armamentarium of prevention. And the problem is that we have such an effective modality of prevention and it's not being utilized. And there's a lot of the confusion because of the adherence issue.
Oh, up here? Yeah.
First of all, we're really honored to have you here with us at Aspen. Thank you so much for being here. Andrew, you listed the things that are needed to defeat this disease. All of you represent this really important ingredient of moral voice. So probably all of you faced times when you had to bring forward something that was coming from a really deep place of moral voice. So tell us how that in your own life has played into the work that you've done.
I think the key in any kind of walk of life, whether you're a policymaker, whether you lead an NGO, whether you lead an industrial business, it's very easy to be swept along by the measures of society which nobody actually owns. So, you know, earnings per share, share price, I don't know, winning an election, whatever it is. And I think what's critical when you do find yourself in a position where temporarily you have the opportunity to make choices which can have very broad impact on multiple dimensions, you have to have the discipline and to some degree the courage, I think, to be able to say, I'm going to prioritize that choice or those choices over those other things. It doesn't mean you commit kind of professional suicide in the process, but it means that you embrace the challenge of explaining why you are prepared to try and do two things at once. What I find extraordinary, and you know, I'll speak from a business perspective perhaps, is how often people diminish the choice to it's this or that. You either make money or you do the right thing. Mm-hmm. It's a completely ridiculous artificial choice. The real challenge to everybody should be how do you do both, right? How do you create a sustainable business with decent economic returns to allow you to invest in the next thing and the next thing, and at the same time, find ways to challenge your business model or the business model of your industry to be able to achieve more. And I think HIV actually is a phenomenal example of that. If you look over, I mean, you've heard, early mid-80s, an unknown disease arrives. Within 3, 4, 5 years, the first drug surfaces through government industry collaboration. Within 10 years, there is a remarkable armamentarium of drugs developed. 5 years after that, the drugs are generic and cents on the dollar, which is essentially the business model. Prices are high to start with, but we always forget you get them for cents for infinity, right? Once the patent's gone, they're cheap for a long time. And that model has worked remarkably well. You think then about the way in which the industry has flexed its intellectual property enforcement regimes to try and allow as many countries as possible to get more rapid access. Those are just examples of where I think people have been able to try and do both two things at once. And the net is we've been able to continue to innovate. There are more drugs coming. There is work in vaccine. More people are being treated. Not enough, but more than you would have predicted at the beginning. Was it smooth? No. Were there controversies? Yes. Did we learn? Yes. Did it get better? Yes. Should we give up now? No.
So back in 2002, when President Bush asked me to go to Africa to see if we could put together a program that could be transforming, the discussion was, should we put a lot of money on research to solve problems, or should we immediately take a look at what the challenge is? So, you know, I had been to Africa multiple times during the HIV/AIDS epidemic, but when I went in 2002, and this was at a time when we in the United States had life-saving medications for the previous 7 years, beginning with 1996. And something that I felt all along that was really articulated by the president himself is that I think that even if it costs us as a country, that we have a moral responsibility to, as a leader, as a planet leader, as a leader in the world, to provide for those who don't have the capabilities of providing for themselves, even if they're not in our own country. Because we do live in a global community, and we don't just live in one place. And I felt, and I still do now, that what we're doing with PEPFAR, what we're doing with the Global Fund, isn't just a favor, it's a moral responsibility as a nation. And not everybody agrees with me on that.
I've had the privilege of having learned from and being kind of, I say, raised by people from ACT UP and other key organizations in the AIDS movement. And you know, at a time where everyone thought that AIDS drugs were too expensive, too difficult to administer, health systems too weak in the global south, they, many of them began to demand that be the case. I've learned from that to reject conventional wisdom and the status quo when it doesn't advance equity, to ask the questions that need to be asked of the status quo when it doesn't, because then it means it needs to change. And I think that's one of the beautiful things about human innovation, and is that we can move beyond them, we can change them. So you talked about the generics being brought on in 5 years. It wasn't brought on at the will of the drug companies, it was brought on because it was demanded. It wasn't supposed to be a 5-year patent, it was supposed to be 20-year patents on some of these drugs, right? And so we need to, I think, really rejecting conventional wisdom when it doesn't align with the rights and with the well-being of people around the world is something that that's how I find my moral voice, is to check when something's not aligned. So when I hear, sorry to pick on you, Andrew, the pharmaceutical industry say, you know, that the R&D costs and the manufacturing costs and all of that are driving the price of drugs, why not challenge them to share those costs? You know, many of those costs are secret right now, and we can't have any accountability if there's not transparency. Again, because I want to challenge the conventional wisdom that we have to have a model that even starts off with drugs at this price and causing slower access to drugs for people around the world. So that's how I find my moral voice.
Yeah, right there.
Hi, my name is Christina Delicay, and I work with the North Carolina AIDS Action Network, and we do advocacy and lobbying and policy reform for people living with HIV and AIDS in North Carolina. And one huge barrier that we encounter in our work is stigma surrounding HIV generally, but also people in communities who are disproportionately impacted, whether it be lower income communities, communities of color, the LGBTQ community, et cetera. So I want to know from you guys, what do you think it will take to either remove or reduce the stigma that's a barrier in treating HIV and really prioritizing this work?
That's a really difficult issue depending on, you know, back in the day when we knew very little about HIV, there was fear and the unknown, and stigma seems to follow unreasonable fear. As people began to know people who were HIV infected, how they began to appreciate that it's a virus, that's the problem, not the person, stigma alleviated a bit. But there are still certain pockets throughout the world, even in our own country, sadly, where stigma is there, but it's so steeped in so many other things. I mean, inherent prejudice against the LGBTQ community, inherent racism, those kinds of things sometimes can't be unlocked from the stigma associated with HIV. And when you have a double whammy, when you have the stigma associated with a difficult disease and the stigma associated with who you are, it becomes very difficult to change that in some people, although we have to keep trying. And I think by educating people, and it's a steep hill to educate people who are inherently racist, who are inherently prejudiced against the gay community. But nonetheless, we have to keep trying to educate people that when it comes to HIV, it's the virus that's the issue, it's not the person.
HIV status created, HIV created and came with its own stigma, but the vulnerability in the first place, why people got the infection, was already due to ingrained discrimination, prejudices in society. So, I don't think we can fight this fight without allying and linking arms with the fights for racial justice, for LGBT justice. As an organization, we work on access to HIV treatment for people around the world, but I still find myself when gay activists or gay men in Uganda are attacked at a pride event by police and raided and dragged out and put into prison, I'm on the phone getting every media outlet, calling the ambassador, trying to make sure that that's addressed, because we can't fight the HIV epidemic without addressing those problems too.
Right there.
Thank you very much. I'm Ngozi Randu with London School of Hygiene and Tropical Medicine. So I just wanted to bring it back to the moral responsibility comment point that all three of you were making. And as we look at the end of AIDS and going back to the vaccine development, and you talked, Jamila, about all the dogged activism that had to happen to make sure that the treatment of drugs went down. So should we be hopeful that if and when a vaccine is available, that it will be affordable? I mean, Andrew, you talked about that's the business model, that when it first comes out, it's really expensive. I mean, the drugs were $18,000 for a course in the first year. Now it's less than 100. Is there anything being done right now to ensure that once a vaccine is available, that it will be affordable, especially to low-income countries where most of the burden is?
Yeah.
Well, I think that's an area where there's been a lot of learning over the last, again, 15 or 20 years, not just in HIV, but in a variety of different arenas. So up until this point in time, the only option we have is drug therapy once people are diagnosed. And we've been able to deploy a variety of different tools to provide large volumes of low-price generics since 2000 across the world. If you look at malaria, where we have been able to develop a vaccine, and I think malaria actually is quite an inspiring analogy for HIV, because bluntly, 10 years ago, people would have said you were nuts to dream you could vaccinate against malaria. But we've figured at least something out. We have it, and the company that developed that vaccine is committed to supply it at a not-for-profit price on a global basis. So that's a scenario where you could anticipate that kind of change. Now, at the end of the day, these technologies aren't getting cheaper to discover and develop. The challenge is super difficult, and somehow or another, there needs to be a way to compensate the people who do the research, take the risk, and all the rest of it, whether that's the company or the shareholder or the government. They all somehow, that needs to be covered some way or another. But what we've developed, I think, as a community over the last 15 years, is a variety of different tools to deal with this question in different arenas. NTD is different to malaria is different to HIV. And I think if we have a HIV vaccine, which I hope we do one day, but it's not trivial, then we're going to have to ask ourselves what's the right business model to make sure that that is accessible. There's absolutely no point, in my view, breaking such a difficult scientific challenge and then not making it available to the people who need it. And that's a global issue, and I think it would be one very difficult to come to a conclusion other than it should be a strategy for mass availability.
Right. So we started a vaccine trial in South Africa in November, which was an extension of the RV144 modestly successful trial in Thailand from several years ago that was 31% effective. So we have a version of that with additional primes, additional boosts, plus a different adjuvant. And we made a commitment that, and the South African government knows that, as well as the rest of the governments, that if in fact a vaccine that's tested in a country where it's proven to be effective, it has to be available very reasonable price to the people in that country. Otherwise, it's unethical to do that trial. In fact, we made, and we being the scientific community, at least at the NIH, that you never ever do a trial in a country in which if the trial is successful, that intervention is not available at a very reasonable price to the country. So I think we have some pretty strong ethical constraints about making something completely out of the reach of individuals in those countries.
I just want to say, though, this is not a global solution, right? A country-by-country solution is not a global solution. Again, the system where it has to be expensive at the beginning, that model does not work for the diseases that we're talking about. It does not work for HIV. And I would argue before we get to the point of having a vaccine, we need to begin to think about that. There have been innovations already. We have the medicines patent pool.
Sure.
We kind of have UNITAID.
I am not, you know, the price of a vaccine is the least thing I'm worried about. I'm worried about getting a vaccine. Okay, I don't think the vaccine is going to be priced to the point of not being able to be distributed
and
widely.
certainly,
I'll guarantee you that.
If we get a vaccine, AIDS activists will fight like hell to make sure that that's not the case. And we know how to do that. We've been successful over 20 years. I think I'm inspired by the movement because I think it's been one of the most successful social movements around health. And that power still exists. We're seeing that power lent to other movements now. So we'll be there, you know, making sure that the drugs are affordable.
We believe you. Well, we have to end on that. But thank you so much, Tony, Jamila, and Andrew. Thank you guys so much for coming. I appreciate it.